Hello, my name's Alice. I'm an F1 at Samwell City and this mini lecture is on dementia. So the learning outcomes for this session, by the end of this session you should be able to describe the main types of dementia including brief pathophysiology and risk factors, consider key differential diagnosis when assessing a patient presenting with memory loss or confusion. You should be able to discuss treatment approaches for dementia in general and specific pharmacological treatments of dementia, and you should be able to use recognised tools to assess cognition. So we're going to cover Alzheimer's disease, vascular dementia, dementia with Lewy bodies, frontotemporal dementia, some other causes of dementia, and then go over history, investigations, cognitive assessment tools, and management. So to start with the definition, dementia is a syndrome of generalised decline of memory, intellect, and personality, but without impairment of consciousness, which leads to a functional impairment. So to start with Alzheimer's disease. Alzheimer's is the most common dementia, accounting for around 50% of cases. And it's due to the degeneration of cholinergic neurons, which leads to an acetylcholine deficiency. Microscopically, you get plaques and tangles. So you get intracellular neurofibrillary tangles and extracellular beta amyloid plaques, which disrupts the functioning of neurons. You also get, on a more macroscopic level, cortical atrophy with widened sulci and enlarged ventricles, which you can see on these MRI scans. Risk factors for Alzheimer's disease include increasing age, a positive family history, trisomy 21, and then vascular risk factors such as history of previous stroke, MI, hypertension, diabetes, high cholesterol, and smoking. So the typical presentation of Alzheimer's is one of gradual deterioration. In the early stage, the key presenting feature is memory loss. So the person might forget names, have difficulties finding words, and not be able to remember recent events. As it progresses, the person will become more confused and might have even more difficulties with language. They also begin to have difficulties with executive function, such as planning and decision making. In the later stages, they will become more disorientated to time and place. You might find them wandering and they'll become less safe at home. They may become quite apathetic, and you can also get sort of personality changes like agitation, aggression, and disinhibition. Incontinence is often a feature, and there's also psychiatric symptoms such as depression and hallucinations. So the second most common cause of dementia is vascular dementia, and it accounts for around 25% of cases. It's due to cerebrovascular disease, so either a stroke, multiple smaller infarcts which aren't necessarily recognised as strokes, or due to chronic small vessel disease of the brain. So the risk factors are the same as for any vascular disease: hypertension, diabetes, a history of strokes or myocardial infarction, high cholesterol, and smoking. So the presentation of vascular dementia, you tend to get a stepwise deterioration with each vascular event, but other presentations include an abrupt onset of dementia, and if you have symptoms that start within 3 months of a stroke, that's also quite commonly vascular dementia. As for any dementia, you need that dementia syndrome, so a cognitive decline which causes a functional impairment. In vascular dementia, symptoms like personality change and psychological symptoms are often much earlier in the disease process than the memory loss, and you can also get focal neurology due to the vascular events in the brain. The next most common dementia is dementia with Lewy bodies. This accounts for around 5% of cases, and it's due to the formation of Lewy bodies in the brainstem and cortex. Key features of dementia with Lewy bodies, as opposed to other forms of dementia, are fluctuating attention and concentration, visual hallucinations, Parkinsonism, sensitivity to neuroleptic drugs, so neuroleptic drugs should be avoided in dementia with Lewy bodies, and disordered sleep, so people can become very rapidly sleepy and they're more awake and struggle to sleep during the night time. The important differential with dementia with Lewy bodies is Parkinson's disease dementia. Typically in Parkinson's, the patient will have the Parkinson's symptoms for at least a year before the dementia begins. The next most common cause of dementia is frontotemporal dementia. It accounts for less than 5% of all dementias, but it is a more prevalent dementia in the under 65s. And it's due to atrophy of the frontal and temporal lobes due to protein inclusions. The main risk factor for frontotemporal dementia is a positive family history, and key features include behavioural changes, which are often more prominent than the cognitive impairment, so things like loss of inhibition, apathy, being restless, and sort of poor social behaviour due to that loss of inhibition. They get an early decline in executive functions, so planning and decision making, which often has a big functional impairment. You get language problems quite early on, and an early loss of insight into the troubles they're facing. So when you're assessing a patient with cognitive impairment or confusion, there are some key differentials to consider. The first main one is delirium. The key differences between dementia and delirium are that delirium has a much shorter onset, over sort of hours to days, and a fluctuating course, and it tends to only last sort of days to weeks. In delirium you get impairment of consciousness, unlike dementia where that's not impaired, and hallucinations are much more common in delirium. Also in delirium you get a reverse sleep-wake pattern, and just be aware that in delirium you can get hyper and hypoactive forms, so don't be thrown by that. Another key differential is depression, which is known as pseudodementia. So in the elderly, depression can present very similar to dementia, with poor concentration and memory impairment. It's important to establish if the low mood or the cognitive impairment was the first symptom when distinguishing between the two. And then finally, just want to be aware of is mild cognitive impairment. So that's when the person does have a measurable cognitive impairment, but the function is preserved. So they don't really meet the criteria for a dementia. And some of these will go on to develop dementia, but others won't. And then other causes of dementia to be aware of. So you get some neurodegenerative syndromes, so Huntington's disease. The dementia won't be the presenting complaint of this, and there will be a family history, but it is one to be aware of. And then Parkinson's disease dementia, which we've briefly discussed in the context of Lewy body dementia, but it's where the Parkinson's symptoms will precede the dementia by at least a year. Neurological causes include normal pressure hydrocephalus, where you get the classic triad of urinary incontinence, gait disturbance and dementia, and also intracranial tumours and head injury can present with a dementia syndrome. Endocrinological causes include hypothyroidism and Cushing's, and then also be aware of vitamin deficiencies. So B12 and folate deficiencies can cause dementia, and also thiamine deficiency in the context of alcohol excess can cause a dementia. And then just be aware that in the elderly, if someone's confused, disorientated, not responding appropriately to your questions, it could be due to hearing loss or visual impairment, and that's not a true dementia. You just need to correct those, and hopefully they'll be fine. So important things to think about in the history with someone for dementia. So first of all, you'd want to talk to the patient and sort of see what experience they're having. So are they forgetful? Are they forgetting things such as names, places, people? And how is that affecting their function? So are they okay cooking for themselves, handling money? Are they navigating themselves? Are they getting lost? And are they losing things? Always take a thorough drug history and just sort of have a quick review of that drugs list and see if there's anything that might be contributing to confusion. Have a look at the past medical history, see if there's any conditions that might be a risk factor, such as history of strokes or MIs and things we've discussed. So it's important to consider the social history as well. So if they're not coping at home and they're sort of approaching the point where they need a package of care, especially if you're clerking them into hospital, that's something important to consider before they're able to go home. If they live alone and they're more at risk to themselves, if they're getting more confused and not functioning as well. And if they're a carer to someone, because then both people will be at risk as their function and cognition declines. And then it's important to take a collateral history, often from a next of kin, a family or friend, or even a carer, asking them if they've noticed the patient becoming more forgetfulness, in their opinion, how's it affecting their function and their day-to-day life, and then any personality change that they're aware of. So is that person becoming more anxious, more irritable, and they're losing their inhibition? And then investigations to consider. So it's important to exclude reversible causes, and how you approach this will depend on the presentation. So you'll often do routine bloods, so full blood count, UNEs, LFTs, CRP, and then include things like B12, folate, thyroid function, calcium, liver function tests, just to rule out any acute pathologies or reversible causes of dementia and confusion. And if you've got a more acute presentation, then you might want to rule out cause of delirium as well. So a urine dip, which technically you should only do if they're under 65 because of the high false positive rate as you get older, and an MC&S just to rule out a urine infection really, and a chest x-ray also to rule out causes of infection. But if it's a more sort of chronic history over months, that's not going to be as relevant. Imaging in dementia isn't usually indicated unless you've got an obvious focal neurology, in which case you want to rule out a vascular event or another structural lesion in the brain. If they're under 60, because that's quite unusual, or if there's a sudden decline, which again would make you think there's been some kind of vascular event. And imaging options are, in that case, if you're thinking something acute, is CT scanning. And then specialist services might use more specialised imaging to distinguish between the types of dementia. So options include MRI scan and a SPECT scan. So now going on to think about cognitive assessment tools. So there are different tools designed for different purposes. NICE recommends a brief, validated screening tool, such as the 6-sit, which is pictured here. So that should be quick and easy to use with every patient. And you can use that if you suspect dementia, just to briefly assess the cognition. Another one to be aware of that's often used in hospital, but this is more to diagnose cognitive impairment in the context of delirium rather than dementia, that's the AMT. The GP cog is often used in GP, and that's another one which screens you for a cognitive impairment, and then you might consider getting a collateral history to sort of add to that. And then another one that's quite useful is the MMSE, so the Mini Mental State Examination. I've provided a link to that in the references, and it's used to assess the severity of Alzheimer's dementia. It will assess a range of cognitive domains, including memory, so that's quite a useful one. Obviously, they have different lengths of time that they take to complete, and some are sort of easier to use, but they all should be quite brief. In terms of management of dementia, the first thing to think about is non-pharmacological management of dementia. So most people will be referred to memory clinic for specialist assessment and management. It's important to manage risk factors, so those vascular risk factors we've discussed, such as cholesterol, blood pressure, smoking. If you can encourage smoking cessation, get a good control of blood glucose, good control of blood pressure, those are really important. And then in terms of function and their ability to live independently, you might consider therapy input, such as physio to get them more up and about on their feet and more safe at home, and OT to look at what devices can be put in place to help them live more safely. Support groups, such as those run by the Alzheimer's Society, can be useful not just for the patient, but for the family of the person living with dementia as well. You might need social care input in the form of a package of care, or even in sort of financial support and navigating benefits and carers allowance and things like that. It's important to think about advanced care planning, so things like before they lose capacity to make these decisions for themselves, appointing a lasting power of attorney, having a think about preferred place of care if they become unable to live alone in their home, and having a think about advanced statements to refuse treatment and things like DNA CPR. It's also worth noting that if you have a diagnosis of dementia, you have to inform the DVLA. It doesn't mean that you have to stop driving immediately, but it does just mean that you need to be assessed, and that will be reviewed on a regular basis. And then going on to think about pharmacological management of dementia. So there are two main groups of drugs that are used in dementia. The first are acetylcholinesterase inhibitors, so they are donepezil, galantamine and rivastigmine. So these drugs are indicated for mild to moderate Alzheimer's disease, and they can also be used in mixed Alzheimer's disease and vascular dementia. They're also used off-licence for dementia with Lewy bodies, but they can only really be started by a specialist. Be aware that they're cautioned in cardiac arrhythmias, they're also cautioned in peptic ulcer disease, asthma and COPD, so you have to be careful when prescribing in these groups. The second drug that can be used is memantine, so that's an NMDA receptor antagonist, and it's licensed in severe Alzheimer's disease, either in addition to the acetylcholinesterase inhibitors, or if the acetylcholinesterase inhibitors aren't able to be used. Another important point, if you're prescribing for people with Alzheimer's disease or cognitive impairment, is trying to reduce the anticholinergic burden of your prescribing, because if you've got a high anticholinergic burden, that's just going to worsen the confusion associated with that. And then just having a think about the behavioural and psychological symptoms of dementia. So these are things like the agitation and distress that people with severe dementia can experience, and these are often much more difficult to manage than the cognitive symptoms, and they can be quite distressing both for the patient, their family and friends, and for the staff looking after them. So initially, you can try to use non-pharmacological interventions. So having a think about why that patient is distressed. It might be something that's quite easy to treat if they're in pain and they're just not able to tell you. If you can figure that out, then that's quite easy to fix. It could be infection, constipation, anything that can make them feel unwell. That would understandably make them distressed, and they don't have any other way to communicate that, possibly, if they're in the late stages of dementia. Often, unfortunately, especially in hospital, when people are confused, disorientated, they're in a new environment, they don't know any of the faces, then it's impossible to treat that cause of distress because that's due to where they are. And sometimes pharmacological treatment is indicated, especially if there's a risk to themselves or to others. But it's important to balance the benefits of treatment against the risks of side effects from that treatment and of polypharmacy, especially in the elderly. So antipsychotics can be used. The only one that's licensed is risperidone, which is licensed for short courses in aggression associated with dementia. But it's really best to avoid antipsychotics in dementia with Lewy bodies, just to be aware. And benzodiazepines are commonly used, but this is off licence really, and there is a risk of falls and worsening confusion with the use of benzos in the elderly, but often you don't have a lot of choice. So just to go through a case here, so I've named this man Bob, and Bob is a 73-year-old man who's been brought into his GP surgery by his daughter Julie. She's a bit worried about his memory. She thinks that he's been confused, and that varies from day to day. She's also noticed that his gait is deteriorating, he's walking with a shuffle, and his movements have become slower. He often swings between being sleepy and then being wide awake, and his sleep is all over the place, according to both of them. On questioning Bob, he agrees with some things that Julie says, but he also describes dogs who are sort of present in his living room, and Julie states that he doesn't have any pets, and this isn't right. So, just thinking about this case, what other information would you like to know from Bob and Julie? What do you think the most likely diagnosis is? What investigations would it be appropriate to order in primary care? And then what management plan would you propose, considering all aspects of management? So have a think about referrals you might make, non-pharmacological treatments, and then finally drug treatments. So the answers are on the next slide, so if you want to pause and have a think, then go for it. So just going through the answers. So in terms of other information that you'd like to know from Bob and Julie, clearly if you have the time in GP you'd want to take a full history, but the key points would include the course of the illness, so whether the gait and movement symptoms came before the memory and cognition, the rough timings according to both of them. Have you think about the course of the confusion, so has this been going on for days to weeks, giving you a picture of more delirium type syndrome, or is it going on for sort of several months turning into years, which makes it more likely dementia? And then obviously you'd want to explore the symptoms more, so sort of exploring the hallucinations, any other beliefs that Bob has, and having a think about those movement symptoms as well. In terms of most likely diagnosis, this is likely to be dementia with Lewy bodies. Without a good time course, you can't rule out Parkinson's disease dementia either. In terms of investigations that you could order in primary care, you'd want to order bloods, so as we've gone through before, so full blood count, UNE, LFT, B12, folate, thyroid function, just the things to rule out a reversible cause of this deterioration. And you wouldn't usually order imaging in primary care, it'll likely be done in secondary care. And then in terms of management, so in terms of referral, you would likely refer Bob to memory clinic. And then other referrals you could consider include physio and OT to look at how he's managing at home and if any adaptations need to be made. You might refer to social services for consideration of package of care if he needs that, or for financial support or carer's allowance for Julie. You might think about referring them to local support groups such as that by the Alzheimer's Society. And then in terms of non-pharmacological management, you'd want to educate them about dementia and Lewy bodies so that they sort of know what to expect, they know what's happening. And that can often be quite reassuring even if that news isn't good news. And then you'll want to be able to educate them about the support that's available to them as the disease progresses. You wouldn't want to do all this in the same consultation, but also as you're a relationship with Bob carries on over the weeks and months, you'd want to think about advanced care planning, so lasting powers of attorney, DNA CPR, all those sorts of things. And then finally, in terms of pharmacological management, so you can use acetylcholinesterase inhibitors or memantine, which are more helpful for the non-cognitive symptoms in dementia with Lewy bodies, but these wouldn't really be prescribed in GP unless you're a GP with a special interest, and they're most likely to be prescribed by an old age psychiatrist. And also these are off licence for dementia with Lewy bodies. So thank you for listening. These are my references, including some links to the MMSE and the 6th SIT. Thank you.